So first of all, I want to both apologize and send my regrets. There was a whole ton of that fluffy stuff that defeats us humans when we try and get around between me and the airport. I was going to turn my computer around and give you all a really nice view of my backyard with snow-covered pines, but it backlit my face and you couldn't actually see me. So you'll be looking at the back of my office. So having said all that, I'm going to carry on with one of the themes that Ellen has summarized from yesterday, and that is the broad theme of the relationship between skill and outcomes. And in this case, the skill that we're going to be talking about is health literacy and health information seeking behaviors. And sorry, that's the outcome. The skill we'll be talking about is literacy, numeracy, and problem-solving skill. Now, in one of my hats as a researcher, I research motivation for reading, especially among children who are struggling to acquire developmentally normal reading skills. And in my role as a motivation researcher, I know that if you give the goal right off, it is strongly motivational for attention and retention of information. So we're going to lead off the presentation putting our goal right up front and not saving it for some secret ending. And this is our goal, knowing how adults with low literacy, numeracy, and problem-solving skills engage in health information-seeking behavior is important. And why? Because those who actively seek health information from a variety of sources are more likely to be cognitively and psychosocially prepared to engage in, and I should say, their own autonomous medical decision-making and with the medical system. So with that background, I'd like to go over a little bit of the kind of theoretical terms, the past research, and a little bit of the background to actually get into the PIAAC data that we looked at. So here's our outcome: health literacy and health information seeking behaviors. The critical concept and the sort of organizing concept that we had for our study was the idea of patient-centered care. And this is the idea that you have really two actors in a health situation. One, you have patients who need to have enough capacity to make decisions. And two, you have healthcare professionals and you have the healthcare system who need to satisfy the requirements of patient-centered care. They need to work at the level of the patients who have the health concerns. So working together to making decisions about health care and health management, management of illnesses and sicknesses, requires both of these elements, and that's what the focus will be. The complex and situational demands of health literacy. If we look and jump ahead a little bit to the policy implications of the findings, and that is, how can the healthcare system be utilized most efficiently within the context of patient-centered care? Health literacy is critical to efficiency of that system. If you look at the 4 or 5 biggest inefficiencies in the healthcare system right now, they are compliance, hospital readmissions, over-testing, and unnecessary emergency visits emerged as the biggest inefficiency. And if you draw a connection across all of those inefficiencies, you can see that communication of health information is absolutely critical to that. If we move down to seeking information and the idea that health information seeking is sort of the first step, where you could almost regard it as a diagnostic step in using health information. If you don't actually go out and seek information, you're likely not to use it. If you can't seek information, you can't use it. It may be diagnostic of whether there is functional health literacy actually happening. So if we switch down from the outcome to the skill part of the equation, we focused on literacy, numeracy, and problem solving. And with the discussion that I just sort of offered you about health information seeking behaviors, you're probably going to sit there and ask yourself, well, surely if health information seeking behaviors are so important to both patient-centered care and efficiencies within the system, surely people have looked at this. And the answer is yes, and I'll present a little bit of the research of how people have looked at this. But where it has not been looked at is with individuals who have challenges in literacy, challenges in numeracy, and challenged in problem solving. So that's why our focus is going to be on individuals who have challenges in these three areas. Using numbers for health is absolutely critical in patient-centered care. If you just think of a few examples of where numbers, in addition to the skills you would expect, reading and writing, if you think about a patient presented with medical statistics, you're about to go into surgery, and the surgeon says to you, now you have to be aware that there is a 35% chance of complications. A number has been thrown at you. How do you understand a medical statistic? How do you understand probabilities? Dosages of drugs would be a more obvious example. Preventative applications such as daily nutritional values that you see on a label of a food product or that you see in a pamphlet given to you by a health professional. And the challenges of digital literacy are especially poignant because digital literacy, because of the structure of the internet, because of the structure of multimedia information, by its very nature combines literacy skills with numeracy skills and with problem-solving skills. So this is the background. Here are the skills. Here are the outcomes we're going to look at. And let's switch, see if I can advance the slide, to our actual research questions. We have two, and I'm going to divide them into a largely exploratory question and a largely descriptive question. And research question one is the one that I would describe as descriptive. And in looking at what sources people who have below average literacy, numeracy, and problem-solving skills, what sources they use, we're going to look at overall level of seeking behavior, but we're also going to look a little bit at differences among the different types of literacy challenges. And the second question, we're going to look at health information seeking behaviors as an explanatory and exploratory. What predicts who will search for health information and how they will search? If we go into the PIAAC data set and the variables we used, our dependent variable was seeking of health information from print media, internet, radio and TV, family, friends, and coworkers, so social sources, and health professionals. Health status is another predictor that we used, and in terms of health status, the past research has shown that not having a current illness is actually positively associated with health information seeking behavior and is an index of personal health engagement. The use of preventative health measures, seeking intervention before illness could be argued to be diagnostic of the level of health literacy that exists. Past research has shown in terms of background information, in terms of non-cognitive variables, that women tend to interact with the healthcare system more than men. Often women will interact with the healthcare system, past research has shown, for men. Age has been previously associated with the use of preventative measures and with health and sickness management behaviors. And race has also been associated with health information seeking behaviors. Caucasians and Asians' status is associated with higher health information seeking generally. The final non-cognitive modifiable factor that, I missed educational attainment because probably it's a little bit obvious. Lower health and literacy outcomes are simply associated with lower education. I jump forward to the one, of course, that I'm most interested in, which is a modifiable cognitive and personal factor, and that is facility in the English language, reading, writing, speaking, and understanding spoken language. And just a side note on methodology, the way we manage this variable, because it's a self-reported facility in the English language, we combined those who responded not well and not at all and called that group poor command of the English language or poor self-reported English facility, and we combined well and very well to make a good index. I'll switch to the next slide. Here's our sample. We took an exclusive approach such that we only included individuals if they were low, and you can see the levels that were regarded as low, that they were low on literacy, numeracy, and problem solving. The advantage of this, of course, is that we have a nice, homogeneous, but high at-risk group. The disadvantage, of course, is that our ability to look at different predictors of literacy, numeracy, and problem solving separately is a little bit hampered. The other note, and just listening to past presentations made it really clear to me that when you chop up a sample like this, especially based on a skill-based factor, we are reducing our variance. We have restricted the variance in literacy skills to the lowest group. And when you constrain variance, all kinds of things happen, both in terms of the generalizability of your results, but also in terms of looking at broader dynamics. So we'll keep that caveat in mind. And jump straight to results. Now, I have 2 results slides, and they have a lot of information in them. And what I want to do is walk through a few of the key findings that you see reflected in the slides. So for this one, what I'll do is first draw your attention to the blue bars. And if you look at utilization of radio and TV sources of health information, you can see that the overall rate, and this is to answer research question 1, is an 80% rate. I mean, people use radio and TV for health information. Now, there's 2 ways to read that. One is the overall statistic, but the other is to say, at some point, everybody has the radio or TV on. And at some point, everybody's going to hear some health information. So we're taking the base rate of 80% as full utilization of that particular source of information. If you contrast that with print media, you can see that a drop in that base rate indicates perhaps not total saturation of that source of health information. And you can see that print media is actually the most consistently lowest used source of health information across our sample. An interesting contrast is when you look at healthcare professionals, and you see that there actually is a distinction between literacy, numeracy, and problem-solving challenged individuals, in that literacy-challenged individuals seem to, and I would, again, I'm offering probably an interpretation that goes beyond the data, avoid healthcare professionals when it comes to accessing health information. This is consistent with past research on struggling readers and the avoidance of any situation that would put their struggles with reading out in the forefront. If we switch to the Internet, the pattern with the Internet usage, and that's the yellow bars, is that there is low usage of the Internet, especially for literacy-challenged individuals and numeracy-challenged individuals. The Internet has really intense demands in terms of literacy skills because it is a print-mediated media, and in terms of numeracy skills. And if you think back to the health information sites that you may have visited, what a healthcare provider is going to say is, oh goody, I have limitless ability to present a lot of text and a lot of numbers. And that degree of saturation of information actually can work counter to the interests of someone who has literacy and numeracy challenges. And then finally, if you look at the, what color are they for you? The gray bars. You can see an interesting pattern that I would call compensatory for people with literacy problems. And if you look at the literacy group, they are approaching saturation for use of that health information source. And in contrast to those who have numeracy and problem solving, almost as a way of compensating for deficiencies in accessing print-based information, people with literacy problems rely more on social sources of health information. So that's really, I'm cognizant of the time, so a brief snapshot of the overall rates of usage of different types of health information. If we switch to the next slide, which there may be a delay, there we are, and that switches to our research question 2. Again, a very complicated slide in terms of our results. Obviously, this is just a teaser for you all to read our report, which goes through in very careful detail all these results. But one way to read this table, and I'll kind of present it to you this way, is to read the rows and then to read the columns. And if you look at the rows, and if I focus on the gender row, if you look, print media, internet, radio, TV, and health professionals, females or being female is associated with a greater usage of those sources of health information. Health status and preventative measures, having good health is associated with higher usage of every health information source. Also using preventative measures. Now, I didn't actually go over this variable, but preventative measures are things like getting your flu shot, getting a mammogram, having a prostate exam, taking a multivitamin, for example. All these things have been associated in the past with health information seeking behaviors, and our study replicates this. Where you get into some unique findings of our study is to take a look at education, and having a high school diploma is associated with higher use of print media and higher use of that print-constrained media, the internet. Having good facility in reading English and writing English is associated with print media, and both of them with the internet and using health information from those sources. And you can see a picture whereby print media and the internet, which are both the most dense and useful sources of health information, are also the most cognitively and structurally, in terms of a person's demographics and education, demanding sources of health information. The other way to read this chart is to look down the columns. And when you look down the columns, it's a more person-centered perspective, because you can look at internet usage, internet health information source usage, and really develop a profile of the kind of person who uses health information on the internet. That person tends to be female, tends to be younger, tends to be Hispanic or Asian status, tends to have a high school diploma, is of good health, uses preventative measures, and is good at writing and reading English. The message here, of course, is one of the rich getting richer. Someone who can use the richest, most demanding source of health information is the person who tends to use it. And all of these factors are associated with better health outcomes. In contrast, if you read down the column of the kind of person who accesses health information via their health professional, that person tends to be female, but tends to be older, tends to be of a black racial status, tends to have good health, uses preventative measures, and has good writing skills. Now, this is one of the ambiguous findings that we have, that writing skills are associated with health professionals. But you can see how the policy implications for the structure and nature of health communications in relation to particular demographics can emerge from this study. So I will switch to our implications slides. And I'll try to switch to our implications slides. There we go. So our key findings. Those who seek health information are more likely to report better health. Again, rich get richer. Participants use multiple sources of health information. Oral sources are generally used more frequently than written sources, and oral sources are used by different people than written sources. And the one sort of confusing finding or suggestive of the need for future research, those who report a higher facility in writing are more likely to use health professionals and the internet. And we'll switch to future directions. One thing we didn't look at is native language status. How does this affect health information seeking behavior? It is part of public policy and is part of legislation that health information has to be provided in the language of use for a particular person. But by necessity, this is a budget-constrained piece of legislation. There's only so much money to produce health information fully in different languages. How do individuals actually use the information they acquire? Our health information seeking really is a proxy or a first step toward full utilization and ultimate link to health outcomes. And what are the impact of writing skills is another compelling question to look at. The most compelling policy implication, in addition to the different demographics and how they use different sources of health information, to me the most compelling policy implication is that facility in written and spoken English is readily modifiable. If someone has a high school diploma, they have a high school diploma. If someone doesn't have a high school diploma, there can often be immense barriers to getting them a high school diploma. Whereas to improve the facility in spoken and written English is much more modifiable. Funding constraint, of course, but it speaks to the cost effectiveness of adult basic education funding, that it can have a ricochet effect beyond structural issues such as your age, such as your race, such as whether or not you have a high school diploma. It can have a ricochet effect on health information seeking and ultimately on health outcomes. Low literacy, numeracy, and problem solving are equivalent in importance across types of access of health information, and this has implications for the content and the curricula of adult basic education. I think that's my last slide, and I probably went over, so I apologize. But thank you for your attention, and I'll be staying online for the next talk and for the discussion.